So in terms of disclosures, I don't have any financial arrangements related to the content of this activity. Today we'll be presenting on MOUD, Components of a Successful Practice, a Team-Based Approach. And as mentioned, this is usually Dr. Bott's presentation. He couldn't be here today. I have plenty to share in terms of experience on the ground in participating in a team-based approach, the perspective of being in clinics where it's well implemented and then those where it's not. So very happy to answer questions about those. And then if you have any kind of questions that are more at that sort of administrative or leadership level, I'm very happy to relay those to Dr. Bott to make sure you get that expert answer. So our learning objectives today are to describe the importance of using a team-based approach, to identify the team members recommended for an office-based buprenorphine program, to describe the roles and responsibilities of each team member, to address how your administration can support building a team, and to recognize how the information that we're going over today can assist you in your particular clinical setting. Now, in terms of the big picture idea here, using a team approach to leverage resources, I think it's helpful to understand where this comes from. And a lot of the information we're drawing from here, it actually comes from the Massachusetts Collaborative Care Model, which is more than a decade old at this point. But they came up with really such great fundamentals that we're all still utilizing them in many cases. And the idea here was, as the opioid use disorder crisis started to really emerge, there was a recognition along the Eastern Seaboard and in Massachusetts that there just was not enough local capacity to meet the demand. So this kind of team-based approach and the principles that undergird it come from this idea of how do we leverage our existing resources? How can we leverage the local capacity to make sure that patients have access to care that is not only accessible but is also top quality? And even though now, the lay of the land is so much more optimistic than it was back then, so many improvements have been made in terms of making sure that patients can access high quality treatment. But we still know, certainly in New Mexico and also beyond, perhaps in Hattiesburg as well, we know that we still have a really significant shortage of prescribing providers and teams that can support them effectively and are trained to do so. So that's the big idea here is how do we make the most of what we have to make sure that patients can access the best care easily and also that providers are not overextended, that providers are able to do their best work and take good care of themselves as well. So in terms of sort of prefatory note on treatment teams, a few things to know are that integrated treatment, so in other words, multiple service providers working together, this is a research-proven model of treatment for people with serious mental illnesses and co-occurring substance use disorders. So this isn't just anecdotally something that people, enjoy working on these types of teams. This is recommended by SAMHSA. Many other regulatory and research bodies do consider it the gold standard treatment approach for this population. And the sort of superordinate idea here is that it allows clients to receive combined treatment for mental illness, substance use, and psychosocial needs, all from one treatment team. And importantly, that treatment team meets regularly to coordinate their care and is able to convey a consistent message about treatment and recovery. So historically speaking, when people were able to engage, with the recovery system, it was often really fractionated. They were having to go to a lot of different places to get care and often were being treated with different modalities. There were sometimes conflicting messages about what recovery looked like and what expectations were. And it was difficult to keep track of all the things that needed to be done to access that care. With this treatment team model, it's as unified as it gets. It's all about the whole team being on one page and making sure that we have a really consistent message that we're giving to patients and that they know what to expect and where to go for help. So a note here, this might sound semantic, but this is one of those cases where there actually are kind of real world implications in wording. People often use the terms multidisciplinary and interdisciplinary interchangeably, but there is a difference. Multidisciplinary just means several disciplines doing their separate pieces. And of course, it's very important to have lots of different disciplines at play. But in an ideal situation, it's actually interdisciplinary, where each of those disciplines is bringing their different training, their perspective, their ideas to one table, and everybody is getting together to formulate a treatment plan and make sure that it's implemented effectively together. So really, it's truly integrated. It's a confluence of all these different disciplines rather than just working side by side, so to speak. So some treatment team concepts to know before we dive into the details. A really big picture piece that I think is easy to overlook here is that recovery is more than just symptom remission or stabilization. It really involves these very big picture qualitative pieces about developing meaning and purpose in the patient's lives. So I think it can be very easy to get focused on the sort of quantitative metrics of, how long were they using, or how long have they been in recovery now? What are the sort of numbers and the facts and the figures? But actually, SAMHSA defines hope as the cornerstone of recovery. And I think it's helpful to take a step back and take a look at how broadly that can be defined, and realize that, beyond just, how long they've been able to go without using, for example, it's also about, do they have people in their lives that they care about and they love? Do they have activities that are meaningful, that help them to get out of bed in the morning and feel excited about a life in recovery? Because those larger pieces are really what keep people sustained in their recovery over the long term. So secondly, including all of the people who work with a patient, and most importantly, the patient themselves in the planning process, is absolutely crucial for success. That goes along with number 3, if the patient does not have ownership of the treatment plan. The treatment plan, of course, is developed by the team, but we want to make sure that there's full buy-in from the patient. Because if there's not, then there's a substantially less likelihood that they're going to do the work that's directed by the plan and get better. A metaphor I know Dr. Bott likes to use is that the patient is the captain of the ship, right? And maybe we're the crew as the treatment team, and we've put the plan together, we have the map, we're kind of running the day-to-day logistics. But the captain is the one who decides if the ship is actually going to sail, and, is able to make sure that it's staying on course, which is the important part. So in order to allow us as the treatment team to do that, there does need to be an infrastructure in place that promotes team cohesion, and that allows us on the team to focus on the clinical work. Because I think many of us have had the experience that if the bureaucracy and the logistics are not addressed effectively higher up, then those tend to soak up quite a lot of our time that otherwise could be directed towards patient care. And then lastly, there's an expectation that treatment teams actually use the treatment plan as the fundamental underpinning for all clinical encounters and interventions. And I do know it's very easy, with how busy most providers are, to sort of treat it more perfunctorily and just kind of go back to the treatment plan when the EHR nudges you and tells you it's time to look at it or adjust it again. But when we treat it that way, we're really underutilizing a huge asset in terms of the treatment apparatus, because a well-formed treatment plan that we're continually going back to make sure that it's aligned with the patient's status, their values, where their progress is headed, that's really kind of the guiding star in making sure that the whole team is on board and that it's accurate. That's a huge part of making sure that the patient is able to stay retained and engaged in treatment. In terms of the components of a successful team, we'll talk about program manager, recovery coach, therapist, pharmacists, advanced practice nurses, and physician's assistants, as well as physicians. And of course, this could look a little different at each agency. We're just kind of hitting the most common points here. So as far as team structure, the people on the team, there's a core, sort of an inner layer, and that includes the client and the primary treating providers who work with the client regularly. And then the extended team, these are kind of more satellite people in terms of service providers. The ones that I often think of are dentists, because that can be a real item of concern, I know, for a lot of patients with substance use disorders. They're not seeing dentists too often, but when they do, they often have a lot of apprehension about them, and there can be some unique procedures involved. So it's really helpful when we can draw in those providers and make sure we're all on the same page, because usually they're at other agencies in most cases. And then, of course, also concerned significant others. So really, whenever possible, and certainly as indicated, we do want to involve collateral, caregivers, concerned significant others, family members, et cetera, who are able to make sure that treatment is generalized to the home environment and that the patients are supported as effectively as they are in engaging in treatment. In terms of the structure of the team, so we do want to make sure we have a team lead or a manager that's responsible for the treatment plan and the team as a whole, and that's very often the primary person working with the client. We want to have a coordinator / recovery coach who's responsible for organizing the team meetings, the communication, making sure that all the documents and information is tracked and recorded in the treatment plan. And these people are really heroes, because when they're doing their job right, that really resolves a lot of the kind of busy work documentation stuff that can otherwise take up a lot of time for other members of the team. And it helps to make sure everybody stays on track. An important kind of organizational note here is that it's important to have both definition and flexibility in terms of team role members. We want to make sure that people are not working harder than they need to, and that everybody has their area of expertise. And then also we want to make sure that, for instance, if one of the team members is out, that when it's possible, somebody else can step in flexibly to make sure that the patient gets that care in a timely manner. And that all the providers are able to take the time that they need away when it's necessary. So in terms of the team lead or the program manager, This could be a physician, a registered nurse, a physician's assistant, a nurse practitioner, any independently licensed therapist. There's a lot of flexibility here, really. The main thing is that it needs to be a consistent point of contact for patients. And, you all being providers, it's a little different for you than maybe the general population, but if you have ever had the experience in an unfamiliar healthcare system where you needed to advocate for yourself or a loved one, you may know it can be really frustrating if you don't know who to get a hold of to get your questions answered, to figure out what paperwork you need, to figure out the next step. So really, really important that the patient always knows this is the go-to person to answer the questions. Similarly, they're coordinating communication between team members and between team and patient so that that isn't something that the patient has to navigate, because that right there is one of the biggest reasons that patients drop out of treatment, when they just can't figure out who or where they're supposed to go. Sometimes they may also have some patient care functions. I'll say, particularly within the collaborative care model, but generally speaking, nurses have been most frequently studied in this capacity, and turns out they're very good in this particular role. So in terms of a recovery coach or engagement specialist, again, there's some flexibility in this role. Could be an RN, community health worker, medical assistant, peer support specialist. While there is flexibility in terms of the qualification, it does require training to step into this role. It's pretty multifaceted. The overall idea is that this is expanding services, so that includes administrative duties, some clinical duties potentially. Patient education is a really important one, and I'll say this is one where I really see peer support specialists shine. I think they often are very, very good at being able to communicate in a persuasive way, in a way that's really comprehensible to patients who come from the community. The basics of buprenorphine, what the expectations and requirements of the program are, because we know when those kind of things aren't outlined in advance, that's a big cause of attrition. What is harm reduction? Defining to them what their opportunities are within the clinic and within the community. And in this role, you can always pull in other team members when you need to. Something that I've done in this kind of capacity is I'm very happy to share basic psychoeducation about MOUD to clear up misconceptions and to help the patient talk to friends and families who have misinformation. But anytime they have any kind of specific nitty-gritty question about how the medication works, in their brains and bodies, then I'm going to pull in a prescribing provider to make sure that they get the best and the most accurate information, that I'm not stepping outside of my role. In terms of psychosocial support, this person also importantly is going to check in with the patient to offer support, make any kind of necessary referrals, and then do either phone or in-person check-ins with patients, because as we've said many times on this echo, that relationship with the clinic, the patient knowing that there's someone there who's thinking about them, who cares if they don't show up for their appointment, who wants to make it as easy as possible, that's a huge factor in determining whether they're going to keep coming in when things get difficult. In terms of possible referrals, of course, these can be made by anyone on the team. Some of the most typical referrals that would be made with this population would include 12-step groups. So that could be Alcoholics Anonymous, Narcotics Anonymous, SMART, Smart Recovery. For many clients, traditional healing modalities can be really comforting when they're feeling like the clinic is, a difficult environment to navigate. If your clinic does not offer something that's directly adjacent to an inpatient treatment program or residential treatment program, of course, making sure you have relationships with those in the community so you can make a smooth referral process. Crisis line phone numbers, which now include texts. Ideally, harm reduction sites and things like HIV and hepatitis testing and treatment services would be integrated into the clinic. It's great when those things can be a one-stop shop. So that would include syringe exchanges, overdose prevention, Narcan distribution. But many agencies, of course, don't have that option. If that's the case, making sure that you know where the nearest, the most accessible, the most friendly clinics are, that they can get those. And then, of course, being conversant with what the community resources are. So things like food resources, housing and utility, employment and education resources. That's not only about making sure that patients get access to them as quickly as they can, it's also about showing that you understand that those are important resources and that you're familiar with that aspect of the community, because that helps communicate to the patient that you understand and appreciate the situation that they're in, and that can be really reassuring for them. So in terms of the therapist role, I really, really want to emphasize that while some degree of psychotherapy is recommended for all patients on buprenorphine, it is never required. We never want that to be a deal breaker. There are some patients who are totally open to the medication and do not want the psychotherapy, and that's totally okay. When we can show them that it can be helpful to them and they're open to it, then that's great. It can be very helpful. But the medication is where the survival data is. We want to make sure that the medication is something they always have access to without precondition. In terms of how psychotherapy can help, on the most basic level, one thing that happens when people are early in recovery is they need to learn a really different way to navigate their life. They have a lot more time and energy that used to be directed towards seeking and using substances, and learning how to apply it in positive ways that are going to support them in their recovery is something that often goes a lot better with some psychotherapeutic support. What we also know is that opioid use disorders rarely happen all on their own. So psychotherapy can be really helpful for treating those underlying disorders. A very common one that we've talked a lot about on this echo is PTSD. And we know that integrated treatment for OUD and PTSD is really the ideal scenario and is likely to lead to the best prognosis. Whenever it's possible, we want to be able to offer as many evidence-based modalities as possible, since there's so many different types of patients and so many different stages of recovery where they apply best. So some of the classics, of course, are cognitive behavioral therapy, relapse prevention, motivational interviewing, contingency management just has phenomenal research with substance use disorder population. And of course, 12-step facilitation is a classic and well tolerated by many patients. Of course, again, the ideal scenario is that the agency has a behavioral health team in-house, just because that makes things smoother for patients. But in the many cases where that's not an option, again, you just want to make sure that you have relationships with referral sources in the community to make that as smooth a path as possible. So in terms of the role in the team, I think people often underestimate how important pharmacists can be or how multifaceted their role is. So of course, naloxone distribution, and then education really at every level for patients, for first responders, for the community, for physicians on things like chronic pain management practices. That education piece is key. And then also, I think we sometimes forget that pharmacists are really on the front line. They're often having that, face-to-face interaction with patients on a regular basis. And they're often the ones who are going to be the first to spot concerning behaviors, so that we can identify yellow and orange flags before they turn into red flags and make sure that we're giving those patients all the support that they need. So in terms of APNs, PAs, midwives, physicians, of course, can also manage or administer naltrexone. Then there's the physical examination, assessing for appropriateness for treatment, providing the prescriptions. And then historically, physicians have sort of been the centerpiece in terms of providing training and education to the rest of the team. So this is a breakdown, and I'll say actually this comes from the Massachusetts collaborative care model. So even though this is more than a decade old, this sort of breakdown of who needs to be trained on what hit the fundamentals so well that we're really using essentially the same model now. There's not too much to improve on. And you'll notice that there are some roles where it's only specific people within the team who are going to need the training. I'd like to just linger for a moment on the ones that say all staff. So that's number 3, 4, and 6. So a basic understanding of addiction, handling challenging behaviors and setting appropriate boundaries, and then addressing staff concerns for working with people who have addictions. These are things that we know, if we're doing everything else right in the clinic, but patients come into the clinic and they sense that people have biases or prejudices, or they feel that they're being treated in a stigmatized way, that's just a really quick and unfortunate way to lose patients. Whereas, I can certainly say on the behavioral health side, it's something patients talk about a lot, how meaningful it is to them when there's a friendly security guard that they can joke with, when there's friendly faces at the front desk, and when they have little relationships with all of the providers on the team. So this is just one of those areas where, I think it seems so simple, but it actually can make a really big difference for retention and engagement and treatment, to make sure that everybody on the staff understands that some of the challenging behaviors that often come along with this population very often come from a place of fearfulness, of having been alienated from the healthcare system, of having to deal with quite a lot of stigma in the healthcare system, and being able to respond effectively to make sure that the provider's well-being as well as the patient's well-being is protected. So I mentioned before about the Massachusetts collaborative care model. The breakdown here is this is really where the main idea of the team-based approach came from. And this again was more than a decade ago. So back in the dark days of data waiver, as they say. And during that time, it actually increased waiver physicians 375% in 3 years. It's very, very impressive. And then on the patient side, it increased patients on MUD, including minorities, which traditionally have been a very difficult population to reach for MOUD in this region, very significantly. And as I said before, nurse care managers were central to the process. What they found in terms of the best ratio was that one nurse care manager plus one medical assistant could handle 125 patients. And that was, efficiently without them feeling overextended. So that's, obviously financially viable and sustainable. That's really a very impressive ratio, and it testifies to the fact that a really well implemented team-based approach is a win for everybody, right? It's win for the organization, for the providers themselves, and for the patients. But again, the idea here is that this was just all about leveraging local capacity, and that's still something we're trying to do, even if it's in a slightly different context now. So this is an illustrated flow of the office-based opioid treatment with buprenorphine within the collaborative care model. You can see if you just scan as you go through this how central the role of the nurse care manager is here. So it's not just, the initial screening, it's also supporting the physician, really at all of the steps along the way. And then really important pieces like the stabilization monitoring, the maintenance with follow-up, et cetera. You see that the nurse care manager is really the copestone of this process to make sure that all of the other team members are freed up to use their unique credentialing in the areas that they're necessary. So this is really just a slide for your reference, so you can see what that initial screening assessment looks like. I'll draw your attention to the sub-bullets in the middle because this is just something that I think we can't reiterate enough. That's educating patients about buprenorphine. So that's what buprenorphine is, what to expect from treatment, risks and side effects. This is one of those things where we know from the literature that patients very often come in with a lot of misinformation about what MOUD is, how it works, what the implications are. And the faster we can get to clearing up that misinformation and replacing it with correct information, the more likely we are to be able to effectively engage and retain those patients. We really don't want there to be too many surprises for them. And if there are things that go differently than they're expected, we want to make sure they know who to contact to address it as quickly as possible. So that leads to the importance of training. Of course, historically, the waiver training, now things fortunately are different. We're wanting to make sure that, everybody who has the DEA capacity is able to prescribe. And, like we said before, if you have any colleagues who aren't, but they're maybe on the fence or they're maybe prescribing curious, please be sure to send them our way so that we can help leverage that local capacity. So again, the Addictions and Buprenorphine 101 training for all staff, like mentioned before, it's really important that everybody understands the big picture, of this population, of how substance use disorders occur and are cultivated and how to engage effectively with this population. And then ongoing trainings, shadowing opportunities with experts, clinical support, telehealth and email backup. This is going to sound familiar because this is, of course, what we're trying to accomplish here on ECHO. And then an important piece here is a public domain policy and procedure manual that's a living document because we all know that the landscape of substance use disorder treatments is changing very rapidly these days, and we want to make sure we have all of the best and the most recent information. Again, a reference slide in terms of the topics that are covered in that office-based opioid treatment, the core training program. It's going to look very familiar because it's very similar what we try to do here on this ECHO. And then I'm just going to close up quickly with the administrative role in terms of successfully implementing MOUD. What comes up in the literature a lot in terms of barriers to implementing MOUD is that there can be a lot of administrative barriers, whereas when there's a supportive administration, things go through much more smoothly. So that includes supporting the clinical team, facilitating regular meetings with open communication, so just kind of general good office well-being. Coverage issues, we know there's a lot of burnout in this field. We want to make sure that providers can take the time that they need away, while patients also are able to make sure that they get the care they need in a timely way. That goes to the appropriate staffing and the ratios that we discussed. Allowing time for training and continuing education. So again, things are changing so quickly. We want to make sure everybody has the most up-to-date information. And then, of course, creating clinic policies and guidelines in conjunction with the team so that it's not all kind of from the administrative perspective. In terms of what you can do right now, in closing, being an advocate for your patients is always creating an accepting, patient-centered environment, and alongside that, combating stigma in the clinic, in the community, and beyond. And then, of course, working with whatever leadership level you have access to enact policies that are going to benefit communities. I know policies seem kind of vague and bureaucratic, but policies really do save lives. So doing what you can to support things like funding for treatment, drug take-back programs, education aimed at community members, et cetera. All right, so a lot of information in a short amount of time. I'll stop sharing and seeing if you all have any questions, comments, or thoughts.